Welcome to the Reality Meets Science podcast. I am Dr. Tom Rafai, your host. I'm board certified in internal medicine, lifestyle medicine, and a past president of the National Board of Physician Nutrition Specialists, and am honored to welcome today Professor Emeritus David Spence of Neurology and Clinical Pharmacology, Western University, and the Director of Stroke Prevention and Atherosclerosis Research Center at the Robarts Research Institute in London, Canada. Dr. Spence has had me following since, several years back when I read an article about egg yolks and maybe more specifically dietary cholesterol, not for those at high cardiovascular risk. And Matt, it was detailed, it was powerful, it was well referenced, and it wasn't the last time we heard from Dr. Spence about this topic. Thank you so much for being on today, Dr. Spence.
My pleasure.
One of the first things that in a lot of heat comes from whether people have conflict of interest and so forth. I want to freely admit I would love to eat lots of steak and eggs if I could. I have a very high lipoprotein, little A level. I am a flexitarian. I by no means have any verboten foods. It's all about how often and how much. So I don't have any interest in necessarily in. I wish that dietary cholesterol could be eaten in the thousands of milligrams a day. That would be my wish, just to be clear here. In that regard, there has been calls for experts espousing on nutrition to make, declare in some way, shape, or form how they personally eat. Would you describe yourself as a flexitarian, more following Mediterranean? Are you a vegan? I really honestly don't know.
No, I follow mostly a Mediterranean diet. And with regard to eggs, I use egg substitutes. Like Better Than Eggs is in the US. We have Egg Creations. There are a number of cartons of eggs. It's basically egg white with coloring and flavoring that is very good for making things like omelets and frittatas and virtually anything that calls for eggs. So you don't have to eat eggs, and you shouldn't, because the egg yolks are loaded with cholesterol, and they also have something else in them that's bad for the arteries. Phosphatidylcholine is converted by the intestinal bacteria to something that then gets oxidized by the liver to form something called TMAO, trimethylamine oxide. And it's bad for the arteries, as is the cholesterol. And 2 egg yolks have about a third more cholesterol than a Hardee's Monster Thick Burger with 2 8-ounce patties of beef and cheese. It's really hard to imagine why people don't understand that eating egg yolks is not okay for people at high risk of vascular disease. And to take that back to the very beginning, if you live in North America and you espouse to, you wish to live to a long, an old age with a healthy life, it's never too young to start staying away from egg yolks.
Yes, I mean, maybe other than some rare occasional issue, what we call the 5% fun zone, I personally agree. But I'll tell you some of the arguments because I want to play devil's advocate. Some, for instance, believe that the absorption of dietary cholesterol is very little, except for very, very few people. I'm not saying I believe that. I'm just asking. In your case, what fraction of the population is there may be a bell curve of some that are hypercholesterol absorbers. I did a personal experiment in over 10 days in Costa Rica of eating 2 egg yolks a day, and my LDL particle concentration would have gone from the equivalent of less than 100 milligram per deciliter ApoB, we were using NMR at that time, to a 40% increase. It was 1,400 nanomoles per liter, or what would have been the equivalent of over 130 or 40. I'm clearly a hyperabsorber, but am I a rare bird?
No, on average, dietary cholesterol intake raises plasma levels of harmful lipids like oxidized LDL, especially oxidized. And that's the thing. When you eat foods, they're cooked, and they increase your oxidized LDL, maybe even more than your regular serum cholesterol. So I would be surprised if there are more than a very small percentage of people who don't have a significant increase in their harmful lipids from eating egg yolks.
And is the way that we're measuring them, which is often in the fasted state, Although we don't need to be fasted for a non-HDL cholesterol, we're still stuck in the inertia of fasting testing. Is there any difference? Does it make a whole a hill of beans a difference?
I doubt it.
I,
Um,
I'm only saying that because I remember in one of your papers you mentioned that a lot of the data on how much cholesterol impacted uh, serum cholesterol had to do with the fact that it was being checked in the fasted state, and if we did a maybe a bit better job of checking the postprandial state, or maybe I'm misremembering. I just want to be sure.
well, I think there's some truth to that. That it would be interesting to do something like a glucose tolerance test, do a cholesterol tolerance test. But I don't think it matters a heck of a lot. Eating eggs is bad for your arteries, and increases your risk of stroke and heart attacks and vascular death. And it doesn't, I think it's not the effect on the blood test that matters so much as the effect on the risk.
Right. And I want to dig into that a bit because people can get mired in the markers and that's not that they're irrelevant, but there are other things. You just mentioned TMAO, for instance, which is an interesting kind of emerging area. And who is it out of Cleveland Clinic that published some of the initial data on that? But nevertheless, the conversion of phosphatidylcholine or
And
lecithin.
so would be Stan Hazen you're thinking of.
Yes, thank you. Yes, thank you, Stan Hazen. Being converted through a process involving the liver and gut bacteria to TMAO, which can make, let's keep it as simple as reasonably possible, maybe making the endothelium more susceptible to LDL particle deposition. Would that be, what is the mechanism of TMAO that increases cardiovascular risk
But
in
it
a way that,
also increases blood clotting and it damages the endothelium. It,
so similar to lipoprotein little a, I mean, it increases the odds of a clot forming
yeah,
on damaged endothelium and, for instance, maybe in a more aggressive clot forming if a plaque ruptured.
probably. I can't give you a reference on that.
Nevertheless, at least it's in by terms of physiological logic or credibility, that seems, at least for the public to understand, that there's a compound. And also fair to say carnitine in red meat does the same type of conversion to TMAO.
Right. Yeah. That's
Um,
the other main source of TMAO.
yes, yes. I understand there's varying amounts in fish as well, which is a bit of an interesting, net effect. But nevertheless, as things lean towards a totality, I don't think either of us are saying that cholesterol is the be all end all only risk. Even in the world of nutrition, there's obviously saturated fat and fiber and sodium and so forth. But we're saying that it is a factor. And could you describe some of the data that convinced you that you've published or others, um, in particular, that has convince you this isn't a guess? We see this in peer-reviewed published literature, some of which you've published.
Um, I don't have at the tip of my tongue references to that, but I published it and I can go back and look it up and send it to you. But there's, I think, very good evidence that dietary cholesterol increases cardiovascular risk.
And some of the relationship to dietary cholesterol and carotid artery disease. A lot of people talk about heart attacks, the huge legitimate topic, no doubt about it. But I don't know if strokes get second fiddle, but it doesn't seem like we talk enough about the fact that the same process of atherosclerosis can be multiple vascular beds. Obviously, heart is a big one, but I mean, you have neck, even lower extremity, even intestinal ischemia. But in terms of stroke, you have done some an amazing research in terms of uh, risk, if you can weave the cholesterol story, dietary cholesterol story into that as well. But you have really been a thought leader in how to reduce the risk of stroke.
Well, yeah, and remember that if you're over age 70, most people are much more concerned about having a bad stroke than they are concerned about having a heart attack or of dying. Having a bad stroke is worse than being dead. And the carotid arteries, my contribution to all of this has been that we developed in our lab beginning in 1986 the measurement of carotid plaque in the arteries by ultrasound. And once you can measure something, you can study it. Um, that you pretty much have to be able to measure it to study it in many ways. And it's very clear that serum cholesterol and high LDL, LP little a, they're all involved in the formation of plaque in the carotid arteries, which is the same disease as plaque in the coronary arteries.
And often these plaques are of a level of obstruction that is not causing symptoms. Some even have made the statement that in coronary disease, 1/3 of cases, the first sign is sudden death because you go from a plaque that's not blocking enough to cause symptoms to a, like a pimple popping, I guess, a rupture, and then that blood clot we were talking about prior occurring. How does it, that's more of the
Well,
heart.
it's
How
the
does it
same in the
occur?
carotid arteries.
Okay.
You can have severe stenosis of a carotid artery and have no symptoms. And in fact, that would be usual. There are occasionally people who have a severe narrowing of the carotid artery that might cause symptoms if their blood pressure drops. For example, if they have postural hypotension and they stand up and their blood pressure drops, then a severe narrowing might become symptomatic. But it's usually not symptomatic until something happens.
In those exceptions aside, in terms of a lifestyle preventing stroke risk, what are your suggestions regarding blood pressure targets? I mean, there's some that will say less than 140 is fine, less than 130. The Sprint trial says less than 120. To me, I like people as naturally low as possible without medications, and if they're feeling fine below 120/80. In fact, I think the multi-ethnic study of atherosclerosis showed, I mean, is such a large population as that is, that even risk might start as a systolic, even above 90, not to any significant degree. But in other words, if someone's feeling fine at 98/56, the recommendation to add salt to an asymptomatic individual like that, I don't think is necessarily wise. But that said, what is a blood pressure target? Where should people be concerned after they've checked their resting blood pressure with their back against a backrest and both feet flat on the floor in a resting, quiet environment with a appropriate size cuff at heart level, presuming it's a properly checked blood pressure? Um, what is the target for the average if they've taken over a month or two? And
Um, Probably something like 130/80 would be fine, and even 135 or 136 or so. But if the blood pressure remains above 140 systolic in the long haul, or the diastolic pressure remains above 90, then something ought to be done about it. And that would begin with measures like weight loss and salt restriction and maybe reducing alcohol intake if it's excessive. All of those things will help keep the blood pressure down.
Mhm.
Salt restriction is maybe the most um, important. People don't realize how much salt they're eating. Something like 2 to 3 grams a day would be desirable. People who are salting their food before tasting it are probably eating something like 10 grams a day. And it's
Yes,
because when you eat salt, it causes the taste buds to shrivel, down regulation of the receptors. And so you don't actually taste the salt that's there until you add a heck of a lot. And so when you cut back your salt intake, your taste buds grow back in, and then you can taste the salt that's already there, and you don't miss it as much as you thought you would.
it's like a taste bud rehabilitation.
Yeah.
It takes maybe a few days and sometimes some weeks, but we've seen that in patients quite a bit who go back and have been really adherent, if you will, and then had a bag of chips at the baseball game or a hot dog and went, "What the heck happened? Why did they put
Yeah.
so much?" No, it was the same amount of salt you had before. Your
Yeah.
taste buds have been through rehab. And since we're on the topic of stroke, we interviewed an FDA official, Robin McKinnon, about the U.S. voluntary sodium reduction guidelines, and that there are now, not just in the US, but worldwide, and on the order of over 10 randomized controlled trials showing cutting of sodium chloride with not entirely potassium chloride. That tastes metallic and there would probably be revulsion of taste, but these 50-50 blends of sodium and potassium, if you're going to add something, maybe a little at the end of cooking, just a little sprinkle on top, might be a wise approach at home. Any thoughts regarding that and the ability to maybe for a public health measure, no one would really notice if we just started replacing sodium chloride with a little potassium chloride?
Well, there are many other ways. A little bit of vinegar adds some zip, and spices and herbs. You don't have to have salt to make things tasty,
I love garlic. I'm a
especially
simple guy.
once your taste buds have grown back in.
Absolutely. Absolutely. In terms of the a study that you had shown, I believe an 80% risk reduction for stroke by using the measure of the total plaque volume. That's a remarkable reduction in risk for stroke.
Total, it was total
Could,
plaque area. Yeah.
total plaque area, excuse me. Could
We
you
are
please?
now also measuring total plaque volume with automated methods, but not in our clinic lab yet. It's still in the research lab. But no, that figure comes from a study in patients with asymptomatic carotid stenosis, so narrowing of the carotid artery but no symptoms. They have a very high risk, those patients. They have a high risk of both stroke and heart attack. And we began measuring carotid plaque in about 1986. And in 2003, we had published an article reporting that high amount of plaque was a very strong predictor of cardiovascular risk. And we began using the plaque measurements to guide our therapy, in preventive therapy in these patients at risk of stroke. And we got to the point where we could achieve regression of plaque in most of the patients.
Do tell.
And that was the report in Archives of Neurology 2010. After 2003, when we implemented this process that I call treating arteries, the risk of both strokes and heart attacks was reduced by 80%, more than 80% over 2 years.
Now people are
So
going to
it
wonder
really works.
what did you do for the bio? What numbers do they have to get, whether it's ApoB or blood pressure? What was the protocol that you implemented to achieve this typical regression? We're not promising every individual will
Yeah,
get exactly, but can you give us some
it's
insight, takeaways?
there's a table in a paper in Current Opinion in Lipidology that lists the process, but it starts with measuring the carotid plaque and showing the patient a picture of the plaque in the carotid arteries and showing them on a graph that their arteries are worse, say at age 50, their arteries are worse than the average 80-year-old. And
That's
that really
motivational.
is a motive. That personalizes it. It's no longer statistics. And that makes a big difference to persuading people that they need to improve their diet. And I asked them to eliminate egg yolks and go vegetarian every other day. And I provide them with a recipe booklet that has lots of tasty recipes and lists of cookbooks. And it's about having fun learning to make it tasty. And the diet's really important. Smoking cessation is mandatory. They have to quit smoking. Controlling their blood pressure. If they have high triglyceride HDL ratio, we will often add pioglitazone, which is an anti-diabetes therapy that's good for lowering that triglyceride HDL ratio.
Which may lower
And,
ApoB, correct? I mean, that's in a sense a marker for, you know,
and as far as lipid-lowering drugs, we routinely use statins plus ezetimibe. Ezetrol is the brand name. They
we
work
call it
differently.
Zetia in the US. Mhm.
Yeah, is it? So they work differently. The statin drugs block the formation of cholesterol. Ezetimibe blocks the absorption of cholesterol in the distal intestine. And the combination is synergistic. It's more than additive. So adding
Absolutely.
ezetimibe to 10 milligrams a day of atorvastatin will achieve a bigger effect than 40 milligrams of atorvastatin alone. So it's very important to use both. And in patients who can't take statins, or even sometimes in patients whose plaque is not responding, even though their LDL cholesterol is very low, we'll add a medication in the family that are called PCSK9 inhibitors, like evolocumab or Repatha is the brand name. So we really go after the lipids. We drive the LDL down as far as we can get it, and we try to fix that triglyceride HDL ratio, which is a marker of insulin resistance. That's why we use the pioglitazone
Mhm.
in patients with that problem. Um, and the combination of a really good diet, effective blood pressure control, um, really driving the LDL cholesterol way down and improving that triglyceride HDL ratio and insulin resistance, and an antiplatelet agent like aspirin. But I think the big key to the thing is showing the patients the picture of their plaque. And there's a patient from a paper from Sweden about that in the in the BMJ, I don't know, 8 or 10 years ago, the same thing. And there's also a paper from Cork Arts, and I'm blanking on his colleague's name, at Wisconsin, that's showing people pictures of their plaque improves their compliance with medication. It increases fourfold the intention of a patient to take lipid lowering medication.
I don't doubt
So
it a bit.
it's an important part of the process, and we start with that.
When in the US, and we're talking, by the way, everybody, about a simple ultrasound, there's no radiation, it's done in the neck. And yet we don't really do a good job in the US of showing the pictures. And when it comes to showing the pictures, did you have to go through, usually you just get a written report, right? This is what the physician usually sees. Oh, you have a 20 to 30%, blah, 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 left, right, external, internal carotid. How did you put into the flow of the clinical process? Hey, a radiologist, ultrasound, the reading team. We want the pictures to show the patients. That's
Yeah,
a
our report has a template of two carotid arteries on it, and the plaques are drawn in on the
I see.
template. So they can see in the picture that their arteries are full of plaque. And just to make it more convincing, we usually color the plaques in red.
Understood. Now, when you see and maybe I'll ask a little bit about this since we're talking about prevention. Um, your thoughts regarding coronary artery calcium scores, where they're all the rage, and I have no issue against, but they don't necessarily check for soft plaque, which could be. I'm just wondering, if someone had a zero coronary calcium score, what might you say? I don't want to presume your answer. Check your carotid arteries, just because that's an easy bed. No radiation, no IV dye. We don't necessarily have to do a CTA or an angiogram. Let's take a look at your carotid arteries. Um, any thoughts or maybe seen where there's zero coronary calcium scores, but no, we can actually see some soft plaque right here in your carotids.
There's usually a pretty good correlation, but there are some exceptions. And you do see soft plaque on the ultrasound that you don't detect on the coronary calcium. But I
And
think what's the key thing to me is not just showing that there's plaque there, it's quantifying it. So you know where you're starting from. And when you repeat that measurement a year later, you can tell whether what you're doing is succeeding. And that's the process that I call treating arteries instead of treating risk factors.
and you're actually
The
motivating
objective
them.
the objective of the therapy is to achieve regression of the plaque.
Correct.
And we can do that in most patients.
And checking just the markers is nice. I mean, you're correlating these markers are giving this result, but at the end of the day, it's the anatomy that matters. That's what's going to drive
The
the
amount
risk.
of disease. Yeah.
Right. So when you see though any disease, I mean, some of us are. There's data, for instance, on coronary artery calcium scoring that if the score is anything above zero, there's some degree of mortality risk increase. Not that a 1 or a 6 or a 7 is major, but it's different than a zero. When you see a 20, 30% blockage, or where's your threshold of concern, or what do you do with when you see the process is there, but it's early? Do you have a moderate way of attacking it, or what's the difference?
Well, we're not really looking at percent blockage. We're looking at the amount of plaque in the artery wall. And the arteries actually get bigger as plaque develops. So the narrowing isn't an early part of the process. It's
That's right.
late.
That's
It's
right.
usually the narrowing is the result of a plaque rupture with thrombosis and fibrosis.
Yeah. The
But
plaques typically
you
grow
can,
into the artery wall. That's correct. Yes. So
yeah.
if you see something early in the way that you are measuring, that is there, there's no question something started. Is there a certain threshold though by which you say this is a case we have to attack aggressively? Here's moderate. Here's we can watch and wait, or any spectrum at all in terms of the measurement?
Well, I would look at how their plaque burden compares with that of other people their age. And if you're 30 years old and you have the arteries of a 50-year-old, it's time to get going on prevention. If you're 72 years old and you have the arteries of a 30-year-old, that's a different issue.
Of
Now,
course, of course. The Is there anything to be said though about the what is the population background we're looking at? I mean, when we look at childhood body mass index, it's based on a population from way back. Obviously, if they just changed to now, the percentages percentiles would change. a lot of people wonder, well, you're looking at a background of a sick population. I don't want to be average. I don't want to even be slightly below average. I want to be really healthy. So therefore, I want to be somewhere more like in the below the 25th percentile. Any thoughts regarding the reference population that we're looking
Yeah,
at?
our patients have been referred for stroke prevention. So on average, they have 3 or 4 times as much plaque as healthy people. The only other study that's measured plaque in 6,000 patients and followed them is in northern um, in northern Norway, and they have data on a healthy population, the amount of plaque they had at baseline, plaque progression, the increase in risk. And our patients have 3 or 4 times as much plaque on average as they do in northern Norway in this healthy population.
And I guess in a sense, it's the good news is that there's room to improve. I mean, if you're coming in, we have things we can do about it, and you've mentioned a number of them already, from obviously smoking cessation to healthy weight reduction if needed, and and addressing the insulin resistance in the process. The addition of blood pressure reduction approaches, whether it be alcohol, care on alcohol, salt, probably more potassium too, more fruits and vegetables, etc. And then if when needed, some statin therapy. But I really like your approach of statin sparing therapy, as we call it, the addition of this ezetimibe that can really add, it can really synergistically work differently than statins to avoid what some people end up having as issues with, muscle pain and fatigue, and on the higher doses, or the concern that there's a slight increased risk of type 2 diabetes at the higher doses. We can get pretty darn good results with 10, 20 milligrams of
Yeah,
atorvastatin.
but even diabetics benefit from statins.
Right. And I've seen only, in fact, when I see it in clinic, I see more idiosyncratic, whatever this average is, 0.1% rise in A1C, which you could address with lifestyle and annihilate that reduction with just 5% weight reduction, for instance. But I've seen it more of idiosyncratic. Never forget one female who went from 5.5 to 6.4. I don't know what beta cell toxicity happened in her case, but I think it is overblown to be blaming statins for type 2 diabetes. I couldn't agree more. Just monitor the A1C, and if you want to use triglyceride HDL ratio, we tend to take advantage of one area that fasting seems to help, using fasting insulin. But whatever floats your boat, it's not usually that much of an issue, and no question that there's a benefit to driving that LDL as low as you. What's the lowest LDL you have seen and you're happy with?
I don't. I have patients with LDLs of 0.2 millimoles per liter, which is a 38 milligrams per deciliter.
That's right. So every millimole per liter is 38, or if you want to just round up, 40. So anytime you see that, you can do the math. And to be clear, a lot of people say, well, the brain needs cholesterol. Any cell can make cholesterol that it needs inside the cellular matrix itself. I mean, there's no problem with a cell that would need cholesterol simply producing it on site if it needed. Is that fair to say?
Yeah, there's no reason to worry about low cholesterol.
Yeah. And that includes male hormones and so forth. I mean, I have a pretty low cholesterol, and I would love to say that I have a low desire for healthy sex and so forth. I don't. Maybe my wife would like me to have less, but nevertheless, um, the cookbook you mentioned, is that available? Can that be something we post a link to, or is it just a PDF, or how would, because immediately when you said that, I'm sure there's a bunch of people going, I want this cookbook from Dr. Spence, or this
Well,
recipe.
I'm pretty sure it can be downloaded from the website of the Robarts Research Institute, but I can also send it to you after we finish this talk, and you can disseminate it.
I'll put it, if you don't mind. Yeah, I'll put it in the description for sure. And there's no doubt people are going to be thinking that, hey, you didn't get that resource. We want that stroke risk reducing resource, because most people listening here are about lifestyle. We're all about medication to fill in the gap, but wherever somebody can achieve it through non-pharma, and pharma being more the icing than the cake, pardon the food analogy, the better. Any use of, you mentioned pioglitazone. Now there's a lot of interest. You're taking me down an area I wasn't expecting, but a lot of interest regarding metformin. It's now in a randomized controlled trial called TAME, or Targeting Aging with Metformin Therapy, led by Dr. Nir Barzilai of Albert Einstein. Any use of metformin for insulin resistance, or just really more stick with the pioglitazone, the TZD?
Well, we used
drugs.
metformin before pioglitazone came along, and we would use metformin if someone has a problem with pioglitazone, but I don't see that much.
Oh, I rarely
Um,
see that. Side effects with pioglitazone are very, very little, other than,
yeah,
it's not as
the
weight
thing
loss
is,
friendly.
but I published an article reporting that low dose pioglitazone gives you most of the benefit without the adverse effects. I think the main adverse effect of pioglitazone is weight gain,
Yeah, 15
and there's
milligrams, in other words, is what you're
and
talking
there's
about.
some fluid retention. Yeah, so 15 milligrams of pioglitazone does most of the effect of the 45 milligram,
Mhm.
but
Uh,
but with less adverse effects.
This was quite a while back. I'll have to go back and search, but I almost remember some data on, preloading. If people were on metformin, they actually had even less side effects with pioglitazone. But very good. I think these are great and wise words to live by. Now, circling back to the issue of dietary cholesterol. And by the way, I do the same. I use egg whites in a carton. It's simple. They can feed the egg yolks and put it in dog food. It's not wasted. Trust me, food companies are not going to waste it. Okay. I mean, you don't have to buy your own eggs and crack them and throw out the yolk and clog up your garbage disposal and all that's a waste. Just go get the cartons. You can get them in egg beater. I like egg whites better than it doesn't matter. Pick whichever one you like. And you can put wonderful vegetables in there and get all these antioxidants and compounds that people claim are in egg yolks from pasture raised chicken and just eat the plants yourself. Just put them in the omelet and you can minus the calories and the cholesterol. And if you want to add a little bit of extra olive oil because it'll zip it up a little bit, then trust me, you'll be better off. Other than rare occasions. Excuse me. I think that's the wiser. Is there a other groups, maybe shrimp or other more which food sources, I guess, would you say? And I presume egg yolks fried in saturated fat would accentuate the issue. But what do you find the foods? Clearly, we know egg yolks are one, but what are some of the foods or food combos that you find are the biggest contributors to uh, patients having a risky intake of cholesterol? I just threw out shrimp as one, but if you could
I
just
think it's mostly meat. I mean, yeah, shrimp is high in cholesterol, but it's expensive and you don't usually eat that much. People, I think, would usually eat more beef than they would if by volume. They would eat more ounces of beef than they would ounces of shrimp usually. And the shrimp it may be better because it doesn't have the saturated fat.
so unless they're obviously sautéing it in butter or and what about that combination of egg yolks and fried in butter or we're not going to spend too much time more on shrimp but anyway since we're on it shrimp then now not just cooked on a barbecue nice and little pan butter flavored spray but in butter the combination of cholesterol and saturated fat dietary
Yeah,
cholesterol and dietary
saturated fat amplifies the effect of dietary cholesterol on the lipid results in blood. So yeah, so I use canola oil usually to cook things, not butter.
Now you're really going to heat up. Of course, canola oil was used in the Leon Heart study, and we know there's plenty of evidence on its benefit replacing butter, lower saturated fat. It even has some polyunsaturated fats in it, and we know its origins in Canada and so forth. And we're just going to get a lot of heat, but that's too bad because the truth is, replacing saturated fat with unsaturated fats is better for your health, and so you can throw all the arrows you want at us. I like personally, I use some grapeseed oil and olive oil. That's kind of my mix. It comes out to something probably that averages out to similar to canola oil, but whatever the case may be. Oh, by the way, in terms of the whole issue of polyunsaturated fats, and we do see now, it used to be the concern years back that too much omega-6 will cause inflammation. And rather than making it I think, a little bit more nuanced as we see plant sources of linoleic acid, whether it is canola oil or grapeseed oil, tend to enhance the liver's ability, not like a statin, but uh, enhance the liver's ability to clear the blood of cholesterol, increasing those LDL receptors the way that statins do by decreasing the production. Um, any uh, any thoughts in that regard, or just generally, yep,
No,
sounds good.
I haven't thought about that.
Okay, fair enough. Fair enough. Is in your life, because we're talking about really, practicing preaching, is fish your flesh of choice? You say Mediterranean. What is, if there is any flesh, if you will?
So yeah, the way that the Mediterranean diet was described by Ansel Keys when they wrote the first papers about it, they did the 7 country study
Sure.
and they compared diet and cardiovascular risk in a number of countries. The Mediterranean diet was described as a mainly vegetarian diet. And so I think it's important to keep your intake of animal flesh down. And if you're going to eat animal flesh, yeah, fish is probably the best. Um, I had a hamburger the other day, a beef hamburger, and enjoyed it. But I seldom eat beef, maybe once a month or something like that. I would eat mostly chicken and fish.
And in portions
And
that are probably more like 3, 4 ounces, not 10. Is that
yeah, a
fair?
lot
Or
smaller than when I was young.
do you
I've
use
learned as
beans
a
and lentils to accentuate legumes to accentuate any protein intake, or
yeah,
yogurt or
you get protein by combining grains and legumes.
Mhm.
So lentils, chickpeas, nuts, beans, all of those things are high in protein, especially when you combine them with grains. So beans and rice, every poor country has a version of beans and rice because that's the least expensive way of getting protein.
Yeah, and you certainly see legumes very consistent across all different blue zones, whether it's edamame in Okinawa or it's lentils and fava beans uh, in uh, in Icaria, or it's in Costa Rica, it would be black beans and pinto beans and etc. In terms of yogurt, where you have not zero cholesterol, it's got a little bit, and especially if it's low fat or fat free, it has very little or no saturated fat. Any thoughts regarding yogurt as a animal source, animal protein source?
No, I don't worry about it. I don't particularly make a fuss about trying to persuade patients to eat it.
Oh, I was actually just asking about you. Is
Oh,
you personally.
I eat it. I eat yogurt occasionally. Yeah.
Okay. The it, on the phys since we're talking about stroke, to round things out, because we talked about a number of other things, from smoking to weight reduction to foods and statins and ezetimibe and even uh, pioglitazone and metformin. Physical activity, where does it fall in the realm of stroke risk or even cardiovascular risk? I guess it was pretty much no brainer. But I want to hone in on stroke. What's your thoughts in terms of stroke prevention and physical activity?
Yeah, something like 30 days, 30 minutes a day of moderate exercise clearly reduces risk compared to sedentary lifestyle.
I like that. So you've made that bet clearly reduces risk. So it is part of your prescription. Would you say it's part of your
Yeah,
lifestyle prescription?
yeah.
And in terms of staying physically active in your case, I mean, obviously you're staying healthy and into I don't even want to ask age because that's not appropriate, but clearly,
All right,
you're
I'm 79.
okay. So I mean,
What I do, I try to do treadmill one day and strength exercises to help my balance on alternate days. And I've just been off. I had foot surgery a while ago, so I've been off for quite a while. So I was up to 95 push-ups before my surgery, but I'm only back up to 60 now. So I'll do treadmill one day and then strength exercises, including push-ups and various things on the alternate days. And I'm only back up to 22 minutes on the treadmill from 30. I was doing 30 minutes. Um, but I'm back up to 22 now after that. I've been off for about 12 weeks with the foot surgery.
well, we're very glad to hear you're coming back. I mean, you are a real jewel to this world of understanding cardiovascular disease, stroke. I guess I just have a couple other thoughts and questions, since we're talking about stroke and brain health and the relationship in terms of dementia, not Alzheimer's, but the second most common, vascular dementia. Any thoughts regarding how this type of an approach might lower the risk of dementia in any way, shape, or form, or
Oh,
what?
sure. If you prevent strokes, you reduce the risk of dementia.
Period.
Definitely. Yeah.
That's it. And that comes by both mechanisms: blood pressure, cholesterol. They are they any independence to one or the other, or is it really just um, the
They
com the
all interact, all of those risk factors.
Mhm. Uh, last but not least, the Canadian guidelines, much smarter than our U.S. Know that we have some, emanating from the U.S. I'm talking about the national guidelines, and now recommends everybody get at least one in a lifetime lipoprotein little a check, which is obviously not going to help someone's stroke risk if they have a very high level. Do you differentiate, or how does that the management of someone has a obviously genetic elevated lipoprotein little a? Does that enhance your concern in terms of stroke or
Yes.
cardio? Mhm.
Yeah, LP little a is a risk factor. There is some evidence that the PCSK9 antagonists like Repatha lower LP little a bit, and there are new treatments coming for LP little a. They're not available yet on the market, but
Yes,
they're in development, and there are some randomized trials published.
it's
So they're
coming soon.
coming.
Coming soon.
But knowing that someone has a high LP little a is simply another reason to be more intensive about their preventive therapy.
Everything else. The one area, and I guess this is the last one, and I've been a little wary about people just simply taking aspirin on a daily basis just because I've seen enough cases of GI and brain bleeds to know that it's not. If it was a new drug today, it would probably go through an FDA process in the United States that wouldn't be quite so the same as it's been grandfathered in. But and in terms of secondary prevention, pretty much no question benefit outweighs the risk. Take your aspirin as directed. Don't. By the way, anybody that's watching us and doctors, myself and Dr. Spence, we are licensed healthcare providers, but we're not yours. So anything that we're talking about here, please discuss with your own licensed healthcare provider. Just
Yes.
giving you information and education that we hope enhances the discussion.
The uh, the first randomized trial that showed that aspirin reduced the risk of stroke was conducted by my boss and mentor, Henry Barnett. He was the PI. It was called the Canadian Aspirin End-to-End Study.
I mean,
Um,
that's just fantastic history. And as we've kind of looked a little deeper into the benefits versus risks, I guess one of the question I was going to get to is in primary prevention, there seems to be some evidence that if you have elevated LP little a because of its increased risk for coagulation and blood clots, you may actually benefit even though your primary prevention and you haven't yet had an event. You're high enough risk that an aspirin might make sense. But have you run into any on the other end, where the aspirin, can does risk for bleed. There is a risk for bleeding. Is there no question about that?
yeah, and so people that are not at risk for cardiovascular events shouldn't take aspirin just because. But of course, virtually all the patients I ever saw were at risk. And you might call it primary prevention, but if I have a patient who has a very high carotid plaque burden, their risk is so high that they're really equivalent to secondary prevention patients. So there's
100%. Yeah.
primary prevention and there's primary prevention. If someone's at high risk, they probably would benefit from a low dose aspirin a day. And
Yeah.
they
And
could use a coated aspirin that might help.
Yeah, it might
Um,
help with some of the GI
yeah.
irritation. Yeah, absolutely. This has been such a great discussion, Dr. Spence. Thank you for taking the time to do this. I mean, world authority on stroke prevention, cardiovascular disease risk reduction in general. Obviously, has a very strong passion and understanding for dietary cholesterol, which unfortunately has gotten a bit out of control since offline. We discussed that the U.S. food guidelines no longer consider cholesterol a nutrient of concern, although that was based on studies that may have been biased towards those funded by ag industry and didn't include controlled trials of people on 0 versus 300 milligrams of cholesterol and the clear increase in LDL risk. And not only that, as you pointed out, there's other compounds, not only in egg yolks, but red meat. Probably the other big source I think you highlighted when the question was asked, what are the two big sources? Because not many people are eating that much shrimp that are beyond just dietary cholesterol in case of TMAO. And we really appreciate your time. Wish you the best in the rest of your recovery. And yes, by all means, please send the recipes. I know that we're going to be asked for that, and if we can put that in the description section, people would be very appreciative. Thank you so much for
Okay,
your
and
time.
I'll also send you a paper about cholesterol and risk, a very strong study from the US a few years ago.
Absolutely, please. We'll put that in the description section as well. So much thanks
Okay,
for you. Thank you.
you're welcome. My pleasure.